Hi, I'm Dr. Ashwin Ananthakrishnan, Associate Professor of Medicine and Director of the Crohn's and Colitis Center at Massachusetts General Hospital. I'm delighted to join you for this year's gastroenterology course. I'll be talking to you about the management of severe ulcerative colitis and pouch-related complications. What we'll do over the next 30 minutes or so is take a very simple step-by-step management of severe ulcerative colitis. And then we'll end up talking about pouch-related complications. And both of these are clinical scenarios where there has been new data and new insights on how to manage, and we have made significant advances. For pouch-related complications, we'll talk about their diagnosis and treatment separately. Let's begin with management of acute severe ulcerative colitis. And even now, 50 years since True-Love-and-Witz criteria was proposed, we recognize that this is still the best criteria for diagnosing ulcerative colitis. The True-Love-and-Witz criteria use the blood in stools, the frequency of bowel movements, and the presence of toxicity-related symptoms as factors to determine whether somebody had mild disease, severe disease, or fulminant disease, which is what we term acute severe ulcerative colitis. For acute severe ulcerative colitis, typically patients have more than 10 bowel movements a day, seeing blood frequently or almost all the time in their bowel movements, and also have associated systemic toxicity, either with elevated inflammatory markers, which in that days was ESR, but now we recognize also CRP and calprotectin, but also an elevated heart rate or an elevated temperature. The number of factors that a patient has prognostic significance. If they have just one factor, their risk of colectomy on follow-up was less than 10%. But if they had three factors, they had almost half the chance of getting a colectomy. We recognize that there are over 1.5 million people with ulcerative colitis in the United States, and obviously many more worldwide. Can we predict who will develop acute severe colitis? And this was very nicely explored in the Oxford cohort, where they took just over 100 patients and followed them and found that about 30% developed acute severe ulcerative colitis that occurred at a median of 14 months after diagnosis. So again, the first year or two of ulcerative colitis is often the most challenging, and up to a third of patients can expect to land up in the hospital. Three criteria: the presence of an elevated CRP more than 10 milligrams per deciliter, or hemoglobin less than 12 for women and 14 for men, or extensive pancolitis, were all associated with higher risk of developing acute severe ulcerative colitis, and they examined this in three separate cohorts. Patients who met all three criteria had a very high likelihood of developing acute severe ulcerative colitis. And so as we think about first seeing these patients in the office, we should recognize these criteria and, importantly, aggressively intervene on these patients to ensure that they get on the most effective therapy early to prevent the need for landing up in the hospital with acute severe ulcerative colitis. Once somebody is in the hospital with acute severe ulcerative colitis, how do we manage them? The very first step is to identify potential precipitants and complications of acute severe ulcerative colitis. Patients may have been non-adherent. They may have thought that they were doing well and decided to stop their medicines, or they may have had insurance or other logistical barriers that precluded them being able to continue their treatment. This is an important factor we need to ask about. NSAIDs have been shown in some studies to be associated with a 20 to 30% risk of a flare-up. And so that's another question that I ask when these patients are in the hospital. It's important to recognize this concept of a paradoxical flare with 5-ASAs. In the clinical scenario we see is patients have had moderate symptoms, they get a colonoscopy and are diagnosed as having pancolitis or limited disease, and are placed appropriately on 5-ASAs as the first-line therapy, but then their symptoms significantly worsen and they land up in the hospital. So this may suggest a paradoxical flare with 5-ASAs, and it's important to recognize that so that we stop the 5-ASAs as a potential culprit. It's important to look for infectious precipitants. Certainly, we recognize C. difficile as the most common infectious precipitant of ulcerative colitis, and so stool testing based on whatever testing strategy is the norm in your institution is important. An important step in identifying precipitants is to look for CMV infection or cytomegalovirus infection. This is only detected using sigmoidoscopy and biopsy, so blood tests and stool tests are not very accurate to identify CMV colitis. And sigmoidoscopy has an additional benefit in that it helps us assess the severity of colitis, which in turn has prognostic significance. C. difficile in some studies complicates up to 47% of ulcerative colitis flares. In my experience, it's been closer to 10 or 20%. It is clinically indistinguishable from an IBD flare. And so it's very important for us to say, okay, to not say that, okay, this looks like C. diff or this looks like ulcerative colitis, because often we're not able to, based on symptoms, make that distinction. It is also important to recognize that traditional risk factors, such as antibiotic use, may not be seen in up to 50% of IBD patients who develop C. difficile. And so the absence of those traditional risk factors for C. difficile does not make it unlikely. The endoscopic appearance in C. diff is very similar to that of IBD, and pseudomembranes are uncommon. So you cannot make an endoscopic diagnosis of Clostridioides difficile infection. The diagnosis is with the stool ELISA or PCR. The treatment is oral vancomycin, which is the first-line treatment. We no longer use oral metronidazole for treatment of C. difficile in patients with IBD. If it is very clearly somebody who was in longstanding remission who now has symptoms suggestive of C. difficile with a positive stool, it's reasonable to give them 24 to 48 hours on just C. difficile treatment. In general, that's not the case, and these both severe ulcerative colitis and C. difficile co-occur, and I do feel comfortable placing these patients on IV steroids at the same time as oral vancomycin as well. Typically, by 48 to 72 hours, you get a good sense of if somebody has responded to vancomycin or not, and can then proceed with initiating rescue therapy. C. difficile infection, as we just saw, again, metronidazole has high rates of failure, and so we don't use that. CMV is found in about 30% of patients with steroid refractory disease. As we already saw, the diagnosis is sigmoidoscopy and biopsies, and specifically with biopsies, it's important to request either immunohistochemistry or viral cultures. Just your simple H&E stain has only a 40 to 60% sensitivity, and so it's not sufficient. The treatment for CMV is IV ganciclovir and then transition to oral therapy for 14 days. If somebody has very, very rare positive cells, that may not be primarily CMV colitis and may not need treatment, particularly if they are responding to standard treatment. As with C. diff infection, generally the first 72 hours of treatment gives you a good sense of if treating that complication will change the case of the change the course of the colitis, or if the person will still need rescue therapy. Imaging studies are not routinely needed in patients with ulcerative colitis unless you suspect either toxic megacolonal perforation, in which case free air or a colonic diameter more than 5.5 centimeters is helpful to point towards that complication. If patients have had a CT scan, again, I do not recommend a CT scan routinely in all patients with severe ulcerative colitis, but if they have happened to have had a CT scan, it's important to look for features such as mural stratification that can predict severity of disease. And in our study, predicted failure of intravenous steroids and predicted the need for medical or surgical rescue therapy. We already talked about the value of sigmoidoscopy in identifying CMV infection. It can also detect severity of colitis. In this prospective study of 89 patients with acute severe ulcerative colitis, a UC endoscopic index of severity of more than 5 was associated with a higher risk of colectomy, and somebody with a UC EIS of greater than 7 virtually always required rescue therapy or coma. The second step in the management of acute severe ulcerative colitis is steroids, diet, and antibiotics. Right? And not all of them have a role. As we think about steroids, the typical starting dose of steroids is about 60 milligrams a day of prednisone or methylprednisone, or equivalent hydrocortisone dose of 300 to 400 milligrams a day IV. Can be given as a once a day or a split dosing. The median time to remission with just steroids is 7 days with no benefit beyond 10 days. So certainly by day 7 at the latest, absolute latest, you should initiate rescue therapy. But often our current paradigm is to initiate rescue therapy if people are not responding by day 2 or day 3 of steroids. About 2/3 of patients will respond. And as you see here in the scatter graph, there really is no value of steroids more than 60 milligrams a day. I have seen patients placed on doses as high as 1 gram of steroids. That is way too high for acute severe ulcerative colitis, has absolutely no benefit and significantly increases risk of complications. So really do not go up beyond 60 milligrams a day dose of methylprednisolone. Bowel rest generally is not helpful in acute severe ulcerative colitis, and I do let patients with acute severe colitis eat as they tolerate. They are frequently already malnourished and are restricting their diet, and I do not want to place additional dietary restrictions on them. Antibiotics are not broadly beneficial in all patients receiving intravenous steroids for acute severe ulcerative colitis. This was a study we published almost 10 years ago now that showed that really for most outcomes, there were no differences between patients who got steroids alone or steroids along with antibiotics. So we should not routinely be using antibiotics unless there is evidence of toxicity or other indications for use. There are other aspects of supportive care that are important. Pain control is very challenging in these patients. It's important to have multidisciplinary input in management of pain in acute severe ulcerative colitis. Certainly avoid narcotics as much as possible. Studies have shown that it increases mortality. And it's important to consider using sedatives and anxiolytics as alternatives to narcotic. And certainly there may be role for other non-pharmacologic measures for pain relief. A lot of these patients are iron deficient, and this is an excellent opportunity to replace IV iron. A lot of patients have significant urgency in that they constantly have the sense of needing to go, but are constantly running back and forth to the bathroom with a sense of incomplete evacuation. And so topical therapy, either a steroid suppository or a steroid enema or a steroid foam, can be very beneficial in these patients as long as they're able to retain it. So certainly do think of that as a strategy. It is critically important to initiate venous thromboprophylaxis in these patients. They are at a very high risk for developing a blood clot, and studies have consistently shown that administering your prophylactic dose of heparin derivative is not associated with increased bleeding, even in people who are overtly bleeding. So we should absolutely be using this. In our experience, about 33% of ambulatory clots occurred in those who were hospitalized within the past 4 weeks. And so we recognize there is a risk when post-discharge, and being prophylaxed in the hospital seems to also reduce the risk of post-discharge venous thromboembolism. So it's really important for us to do that. The third step is early, repeated, and objective assessment of response to therapy. There are multiple predictors that have been described as determining whether somebody is responding to steroids or not. The most well-known are the Oxford and the Ho index, and you see that here on the slide. The Oxford criteria uses a definition of more than 8 bowel actions a day, or 3 with an elevated CRP. The Ho index also includes albumin and colonic dilation in addition to the bowel frequency. And so all these are equally predictive of response to steroids and failure of second-line therapy. You see here in this very nice study that looked at either the Oxford index or the Ho index, showing that it can separate out sort of those who are steroid refractory, those who are refractory to your rescue therapy, and those who eventually need surgery, all significantly higher rates in those who are high risk compared to low risk. So it does not really matter which of these indices you use, except to remember that bowel frequency, amount of bleeding, and your C-reactive protein are going to be important objective components of assessing response. In a study that we published a few years ago, a fecal calprotectin, more than 800, was also predicting the need of rescue therapy. Certainly, we recognize that in a lot of our institutions, the turnaround time for fecal calprotectin is not quick enough to be incorporated in the management of acute severe ulcerative colitis, but certainly if it is possible, then it is an important prognostic variable as well. The fourth step in the management of acute severe ulcerative colitis is very important. It is to initiate rescue therapy, and by that I mean initiate rescue therapy early for steroid refractory disease. What are the options we have for rescue therapy? Traditionally, the first option that was available for rescue therapy in acute severe ulcerative colitis was cyclosporin. This trial that was published in the New England Journal in 1994, patients received either cyclosporin or placebo. It was a very small trial of only 20 patients. And 9 out of 11 patients with cyclosporin responded within 7 days, compared to none of the patients receiving placebo. So you do see a very quick and very marked benefit to the use of cyclosporin. There are certain investigations that are specific to cyclosporin that it is important to do. It's important to get a magnesium level prior to starting cyclosporin. A low magnesium can increase risk of seizures. It's also important to get a lipid panel. A low serum LDL value also portends increased risk of side effects with cyclosporin. The critical point for cyclosporin is that it is not a maintenance drug beyond a few months. And so cyclosporin as a rescue therapy only works if you have a second agent to transition those patients to. Traditionally, this has been azathioprine. In this very nice study that looked at 118 patients treated with cyclosporin, showed that if you were AZA naive, you had a much higher rate of response and a much lower rate of needing a colectomy than if you had already failed azathioprine before. So really having that maintenance therapy you can rely on is important in people you're initiating cyclosporin. The second treatment that obviously we're all comfortable with and use it frequently is infliximab. This nice trial that was published 20 years ago was again a small randomized trial of only 45 patients, and all they got was a single dose of infliximab, either 5 milligrams per kilo or placebo. And they showed that it's a pretty marked rate of response even with that single dose, with about 70% of patients not needing surgery, compared to that same number needing surgery in those who receive placebo. So again, you see a good separation of benefit between infliximab and placebo in this population. More recently, we have also become aware of increasing fecal losses of infliximab. And so this very nice study looked at how much infliximab is in stool after a single infliximab infusion and showed that for some patients you see here in the scatter plot, they have very high levels of fecal loss early on. And so the thought was that people who are not responding are doing so because they lose infliximab in their stool. And so the standard 5 milligrams per kilo dose may not be sufficient for those patients. And we have entertained the concept of what we call accelerated induction, which is a dose more than 5 milligrams per kilogram, or doses that are given closer together than the traditional 2-week interval between the first and second dose. In this Irish study, there was a decrease in short-term colectomy rates between those who received 5 milligrams or a higher dose of infliximab, but there was no difference in the long term. In this multi-center study that we published 5 years ago, we found no difference in the short or long-term rates between those who got a higher dose compared to standard dose. But very, very, very important caveat. At that point, people who are getting a higher dose were generally people who were ill. So what I can take away from this study is that by giving a higher dose, perhaps you're actually rescuing some of these patients so that you're making the outcomes comparable to the standard dosing in a less sick population. What we did find also was that those who got an upfront 10 milligram per kilogram dose did much better than those who got 5 milligrams, and then a couple of days later, they're not doing well, and you gave them another 5 milligram dose. So it is frequently the practice in our institution that when we're using infliximab for acute severe ulcerative colitis, we go with 10 milligrams per kilo as the standard starting dose. And here you see sort of benefit in giving that over chaser 5 milligram doses. So it really is important to hit them hard early. Between the two agents, is there a difference? These two trials that were published a few years ago showed no difference between infliximab and cyclosporin for acute severe ulcerative colitis. There are multiple newer approaches as well that are critically important to discuss because we are increasingly using that. I'd mentioned previously that cyclosporin was important as a treatment if you had something to transition it to, and that it was previously azathioprine. Now we have seen growing data that patients who respond to cyclosporin can be successfully transitioned to vedolizumab, or they can also be transitioned to ustekinumab. So some of these newer biologics can be overlapped with cyclosporin in these reports, and they don't work quickly enough to be used as rescue therapy in acute severe ulcerative colitis. But once somebody has responded to cyclosporin, are very attractive agents to transition the patient to. The second change that we've really seen over the past 2 to 3 years is increasing consideration for the use of JAK inhibitors. And these for ulcerative colitis are tofacitinib and upadacitinib. And the principle for use of JAK inhibitors in acute severe ulcerative colitis is that these are small molecules that may be less susceptible to fecal losses. And in phase 3 randomized controlled trials, if you look at the data, response was seen within 24 to 48 hours for upadacitinib or within 3 days for tofacitinib. So you start seeing very early separations for placebo. So granted, these were not people with acute severe ulcerative colitis. They were outpatients with ulcerative colitis, but still, we do see clinical benefit early with these inhibitors. This was a nice study from the University of Michigan that highlighted that giving patients tofacitinib at a dose of 10 milligrams TID resulted in response in at least 60% of patients, compared and with much lower rates of colectomy compared to those who were treated with other agents. It's important that the other agent group included accelerated infliximab in only a very small proportion of patients, so it's not really apples to apples comparisons, but nevertheless, they were able to show that use of JAK inhibitors was associated with reduced rate of colectomy. We have data on 3 studies treated with upadacitinib. You see the sample sizes here, 25 patients, 12 patients, and 9 patients, all of them showing that there's a response rate of about 50 to 70%, with about a third requiring colectomy. So reasonably high rates of response therapy with these JAK inhibitors as well. And certainly we strongly consider that as at least a second-line salvage therapy, if not first rescue therapy, depending on the clinical scenario. The final step in the management of acute severe ulcerative colitis is it does not end at the starting of rescue therapy, right? You always want to plan for the next step. If they don't respond to rescue therapy, they may need either salvage or surgery, or you need to optimize their maintenance therapy. So the salvage therapy in some studies, either infliximab first or cyclosporin, and cyclosporin followed by infliximab, worked in some people with a reasonably high rate of serious infections. Want to be very careful in doing that. Patients who are hospitalized represent a high-risk group for poor outcomes long-term. So it's very important to optimize their maintenance strategy after their recovery from the hospitalization. Right? So if you establish a diagnosis of acute severe ulcerative colitis, you start them on steroids, we do the flex-sig, we rule out infections. If they are responding to steroids by day 3, then you can transition them to oral steroids and discharge home, but it's very important to optimize their maintenance treatment. If they don't respond, I would initiate rescue therapy, and if they're sort of responding, you can give it another day or 2, but certainly no later than day 5 in making that determination. A rescue therapy has traditionally been infliximab or cyclosporin, and if they respond, we either continue them on that or transition them to a different agent, as we discussed already. In patients who are not responding, we are considering salvage therapy, including JAK inhibitors, and this algorithm is likely to be modified a little as we get more data on the appropriate use of JAK inhibitors in this setting. But obviously, if patients don't respond, then, and we saw even with JAK inhibitors, about a 30% rate of needing colectomy. The operation of choice is a subtotal colectomy with an endoleostomy and Hartmann's closure of the rectum, which is typically done in 3 stages. And I have there on the slide the indications for medically refractory disease. And the most common post-colectomy reconstruction in these patients is an ilioanal pouch. So an ileal pouch itself is not new. An ileum anal anastomosis, not with the pouch, but a direct anastomosis between the ileum and the anus, was reported in Berlin as far back as 1933. But really the continent ileostomy that was described by Niels Koch in 1969 is an option for reconstruction following a colectomy. And But more commonly, we had Alan Marks and John Nichols describe the IPAA in 1978. So it's been around for about 45 years now, initially described as an S pouch, but subsequently modified as a J pouch. And you see here, as highlighted here, what we call the J pouch itself is easier to construct and has a superior function than an S pouch. An IPAA, generally, as we saw, is done in 3 steps. The first step is removal of the colon with preservation of the anal sphincter, along with a temporary diverting ileostomy. The second step is the J pouch construction, which can be either with a hand-sewn anastomosis with the removal of the rectal cuff, or a stapled anastomosis, which has slightly better functional outcome, but does retain a little bit of the rectal cuff. Then as the third step, the ileostomy site is closed and the ileal reservoir functions at the rectum. It's important to counsel the patients on what to expect after a J pouch. The median number of bowel movements after a J pouch is about 6. It's slightly higher as people go old, get the J pouch at an older age. At least one nocturnal bowel movement at night is noted in 75% of patients. Full continence is fortunately seen in over 2/3 of patients, but 12 to 20% may have occasional spotting, and up to 9% at 3 months may have major leakage, and this can decrease with follow-up. Use of supportive medications is very common. Anti-motility drugs, 15% at 10 years. In my experience, that number is much larger. Use of fiber supplements to bulk up their stool is also reported at 15% at 10 years. Again, at my experience, that number is larger. There are a number of different disorders that can affect the J pouch, right? The first, most commonly encountered one is pouchitis. What is pouchitis? Pouchitis is an inflammatory condition involving the J pouch. About 50% of people with the J pouch, if you look at the top pie chart, can develop pouchitis. 50% do not. Among those who develop pouchitis, about 40% can expect one episode of pouchitis, while the remaining 40% may have recurrent episodes of acute pouchitis. About 15% develop a condition called chronic antibiotic refractory pouchitis, and up to 5% of patients can develop Crohn's disease of the J pouch. And it's important to recognize that this is de novo Crohn's disease of the J pouch and does not represent a missed diagnosis. This is somebody who had ulcerative colitis before, who now has Crohn's developing in the small intestine. What is acute pouchitis? Acute pouchitis, as we talked about, is an inflammatory condition of the J pouch. It is a clinical diagnosis and an endoscopic diagnosis. It is not a histologic diagnosis. It presents as increased frequency of bowel movements associated with cramping and abdominal pain. Endoscopic appearance is of diffuse or patchy inflammation of the J pouch with erythema and aphthy. This really is restricted to the J pouch. The afferent limb, which is above the J pouch, is normal, and the rectal cuff is normal as well. This really is inflammation that is restricted to the pouch. Now, there are people who have a normal appearing pouch where if you take biopsies, they can have histologic activity. I would not call that as pouchitis. In our study that we published last year, those patients had a slightly higher risk of developing pouchitis later, but it did not require antibiotic treatment for purely histologic inflammation. What are the risk factors for acute pouchitis? So having ulcerative colitis as opposed to an ileal pouch for FAP is associated with pouchitis. PSC is a strong risk factor for pouchitis. Nearly 80% of those with PSC develop pouchitis compared to 50% without PSC. Smoking, NSAID use, male gender, and higher serum IgG4 or p-ANCA positivity are all risk factors for pouchitis as well. There's not really great effective options to prevent the occurrence of pouchitis. In a small study, BSL number 3 after ileostomy closure was associated with reduced rate of pouchitis at 12 months. Other studies have been more mixed, so I don't routinely recommend that in all patients, but certainly it's an option to consider as the only option available to prevent pouchitis. I would also draw your attention to the AGA guidelines on the management of inflammatory diseases of the pouch. This was just released this year, and it's a very useful document that takes you through the different pouch-related inflammatory conditions and their treatment. For acute pouchitis, the treatment is either oral ciprofloxacin or metronidazole. Ciprofloxacin is perhaps a touch more effective. These are generally given for 2 weeks, but can be given for up to 4 weeks. Most clinical trials use 2 weeks. Most patients will respond to antibiotic treatment. However, some patients have what we call antibiotic-dependent pouchitis, in that they need 3 or more courses of antibiotics a year and have symptoms relapse soon after. Such patients, there is data that VSL-3 as a maintenance strategy after somebody has completed a course of antibiotics may be beneficial. Frequently, there is the need for chronic low-dose systemic antibiotics. This can be ciprofloxacin, it could be rifaximin, it could be cefixime. A number of these antibiotics are beneficial. I try to not use metronidazole long-term because of the neuropathy risk, and I try to get them on the lowest possible dose. So practically, I have patients complete a month of course of treatment, maybe ciprofloxacin twice a day, then come down to maybe once a day for a month and see how they do, and then try every other day, trying to get it down to maybe once or twice a week. And for some people, they are able to reduce the dose to a very low maintenance dose and then remain well. Chronic pouchitis is when their symptoms they're not able to de-escalate the antibiotics and they require the antibiotics long-term. If they are antibiotic dependent that way, we talked about all these options already in terms of long-term antibiotics, and sometimes you need to cycle antibiotics. If they are antibiotic refractory, which is defined as either decreasing or no response to antibiotics, then the treatment for them is directed against the immune system, much as you would treat Crohn's or ulcerative colitis. So there is data on use of steroids, including budesonide in that setting. You can use other systemic immunosuppression. It's a very nice dedicated trial for vedolizumab in the setting called the EARNEST trial that was published in the New England Journal a couple of years ago that showed that that was very beneficial in this population as well. We expect that any of the immune-directed treatments are beneficial. It is unclear if they had failed that treatment for ulcerative colitis. Does that mean they cannot go back on that for their pouchitis? In my experience, and this is what the scattering of data that exists shows, that you can go back to immunosuppressants that they have been on before for their ulcerative colitis as well, and it does still work for pouchitis. Crohn's disease of the pouch, as we saw, affects about 5% of patients who have an IPAA. The diagnosis is made endoscopically and clinically, where it presents as small and large mucosal ulcerations with nodularity, exudates, and inflammatory polyps. Inflammation of a long segment of the afferent limb also suggests a diagnosis of Crohn's disease. Sometimes pouchitis extends just an inch or two. If it's much beyond that, then that suggests Crohn's disease. If they have an ulcerated or strictured pouch inlet or fistula, again, that suggests Crohn's disease as well. Histologically, Crohn's can present with just ileitis on biopsy, so don't look for granulomas. They're found in less than 10% of patients. The treatments of Crohn's disease of the pouch is as for other luminal or complicated Crohn's disease. And like we talked about again, can certainly consider going back to treatment if somebody had failed for their ulcerative colitis. It's a different clinical scenario at this time. This is an appearance of Crohn's disease of the J pouch in one of my patients, showing that typical ulcerated stricture at the pouch inlet or the scattered inflammation higher up than in just the pouch itself. Cufitis, which is the last entity we want to discuss, is inflammation purely of the rectal cuff. You see here, this gentleman has a very long rectal cuff that was almost 2 inches in length. Often it is not that prominent. You see that the pale pink J pouch mucosa is very normal, but the rectal cuff looks red and irritated and granular with friability. The treatment of cufitis is histologically, this is colonic tissue, so histologically the biopsies will read as colitis. The treatment is as for ulcerative colitis. Often first line is topical therapy. It is possible that you may need to initiate systemic therapy, as we just saw for a couple of other indications, but most patients respond to just topical therapy. It's uncommon to need systemic therapy for cufitis. It's important that this rectal cuff, because it's colonic tissue, remains at risk for colorectal cancer in such patients. Surveillance. We also recognize there are a number of other pouch complications that I'll leave it to you on this slide. Irritable pouch is when patients have a lot of bowel symptoms, but a normal pouchoscopy and exam where you treat as for IBS or other functional bowel disease. Pelvic floor dysfunction is increasingly recognized in patients with pouches who present with a difficulty in evacuating. Sometimes a floppy pouch can also present as difficulty in evacuating, where patients need to contort themselves to evacuate their pouch, and it's important to look for that with defecography studies as well. And with that, I'll end my talk, and I look forward to engaging with you in the Q&A session. Thank you.